Hi, my name is Buck Durham. I'm an associate professor of cardiothoracic surgery at the Medical College of Wisconsin and Frederick Memorial Lutheran Hospital. I'm also the director of mechanical circulatory support and ECMO. What I'm going to talk about today is a hub and spoke model in healthcare, what the keys to logistics, getting the necessary support, and the keys to a successful program. Technological advances in medicine have led to really astronomical leaps in our ability to successfully care for vastly sicker patients than we've been able to in the past. This has particularly increased our ability with technological advances associated with care of COVID-19 patients. We've struggled to keep up with a lot of technology in search of an application. However, the care of these sicker patients that employ newer, cutting edge, and often emerging and disruptive technologies is much more expensive and, perhaps more importantly, labor intensive than just standard ICU care. This strains the healthcare systems to maintain financial viability, to be fiscally responsible, and it also leads to competition for the resources to support these advanced therapies, not only the technologies themselves and potential back order or waiting periods to get the technologies, but also, and perhaps more importantly, this competition is for the specifically trained and experienced personnel who have experience with these technologies and their application. Inherent competition for these resources, both between competing health systems, but also within a health system itself, has led to a very expensive duplication of resources, and it also feeds this shortage of trained healthcare workers, which threatens the ability to consistently deliver optimal healthcare to these very complex patients. Hub and spoke models, popularized and originally developed for the transportation industry, have been translated into a myriad of business models and plans, and this includes the healthcare industry as well. And in many places, they've been very well received and very successfully applied. Large healthcare platforms, places like the Cleveland Clinic, the Mayo Clinic, places like that, have been able to successfully enact this hub and spoke network. It's made easier at that level because they own the hub, they own the spoke, frankly, they own the whole bicycle. So they have an easier time with a single governance body to implement the changes necessary. But it's been with varying degrees of success, depending on how this model was applied and how it was sold to both the providers in the hub and the spokes themselves. The development of hub and spoke systems between often competing healthcare systems is more difficult due to the inherent competition for the healthcare dollar and the patients themselves. This has led to some hesitation to get into these programmatic associations, if you will. Development of the model has been more embraced, if you will, between healthcare systems that have a primarily rural platform and footprint, as opposed to more urban or suburban hospitals. The rural healthcare systems tend to have smaller hospitals with more limited infrastructure and resources available. The partnership with a larger community hospital or academic medical center gives them a relatively seamless ability to draw on the infrastructure and the resources of the larger medical centers. And this facilitates a more rapid transfer of the patient and negates the need for the smaller hospitals to financially overextend themselves to try to get these technologies on board. Here you see depicted a hub and spoke model that's just kind of a routine cartoon. And what I've done is I've broken it down. You've got the hub, and then we have looked at it here in Milwaukee as having level 1, 2, and 3 spokes, if you will, with level 1 being the smallest, urgent emergent care centers, very small hospitals with very limited resources and no subspecialty support, to level 2 centers where they might refer that have more infrastructure but are still lacking in some of the subspecialties. And those level 2 centers can take care of a lot of the routine ICU patients, but any complex patient, they may then refer to a level 3 center, which is going to be more of a suburban to smaller city community hospital, which have additional resources and infrastructure, as well as most of the subspecialties represented, such as cardiac surgery, neurosurgery, advanced oncology, interventional radiology, and the like. And those centers can handle the majority of the patients coming in, and they would be linked in a hub and spoke model, as you see depicted here, to the hub, which in our case would be our tertiary or quaternary level academic medical center, which has cutting edge technology, more infrastructure, a transport system, and the ability to handle virtually any patient that is presented to them. And you can see the arrows on this are bidirectional. And part of that is because one of the keys to success, as we'll talk about later, in the hub and spoke model is our ability from the hub or the larger urban to suburban hospital that may be a level 3 to get these patients over their primary problem, have a good assessment, have frequent communication with the referring providers, and get those patients back to the appropriate level center or physician from which they were referred. What are the benefits of a hub and spoke model? Several groups have looked at this, and it boils down to a few tenets that are worth discussing. Number one is consistency. The consistency of having a relationship between the medical centers and between the providers themselves, in addition to administration, provides more of a hierarchical structure for communication. And communication is the key to most hub and spoke models: frequent, frank, open communication. It also provides a uniform patient experience across the platforms, with the consistent association between a level 1, 2, or 3 facility and the hub allows for similar protocols and treatment algorithms, which provide that uniform patient experience, is more settling to the patient, and the results have been a better patient experience as determined by the patients themselves. It allows the smaller facilities to avail themselves of the additional infrastructure and resources of the larger center or the hub institution to which they're referring. Next would come efficiencies. The efficiency is also efficiency of scale, but our ability to centralize these advanced therapies at hub institution prevents duplication of resources and reduces competition for the specialized personnel. This in total benefits not only the patient and the payers, but both institutions as well, due to return on investment and economies of scale at the various institutions. Next, quality. Concentrating the resources and infrastructure in a hub facility offers the opportunity for enhanced quality, which is seen with increased experience, which has been linked to improved outcomes. A smaller facility is doing 10 cases a year of a certain type versus 200 or 300 at a hub facility. That's translated in the literature to improved outcomes with the increased experience of the larger facilities. Well, with any benefit, there's risk. The biggest risk that you concern yourself with at a hub is congestion. Proactive planning is required to ensure that additional capacity is available to allow for accepting a patient at any time from one of your established spokes, as well as for adding spokes as growth and requests demand. With multiple spokes feeding into this centralized hub, it's the responsibility of the hub facility to ensure that resources and capacity is maintained to accommodate the influx from the spoke facilities at all times. It comes down to a never say no policy. Overextension of the spokes. Overextension of the spokes harkens back to transport. And as we'll talk about, transportation is one of the keystones of a hub and spoke model. But delays in transport or due to the transport system itself or congestion at your hub facility can cause overextension of the spoke facilities and having to care for patients for which they're ill prepared because they usually will transport them to the hub facility. This puts an additional financial and personnel burden on that spoke facility. Dissatisfaction at the spokes. This is one of the most common issues between competing healthcare systems. There's a perceived loss of autonomy in managing the patients the way the physicians and providers want, as well as an inherent competitive nature, and that can foster staff and administrative dissent. They feel like we are taking something that they know how to care for, and that's often the case, but it is undertaken with the benefit of resources and infrastructure. The perceived loss of revenue, particularly with healthcare systems and their administrative components, they feel like there is a loss of revenue because they're transferring that patient to the hub facility. And they look at this despite the cost savings in them not having to invest in additional personnel and infrastructure. However, it's also one of the tenets that we in the hub facilities want to try to get those patients back into the community as soon as is feasible from a patient safety standpoint, because then those hospitals and the physicians are not losing financial incentive to transport those patients if they know they're going to get the patients back and they can derive some downstream revenue from it. And from a patient satisfaction standpoint, the patients would rather be seen and be in their own community. They would rather drive 5 or 15 minutes to their level 1, 2, or 3 facility and see their own physician who they may have been seeing for years, as opposed to having to drive hours to the hub facility to be seen by specialists that are largely not needed by the time they're ready to return to the community. Transportation disruptions. Hub and spoke, by definition, is dependent on a robust transportation program, both ground, fixed wing, and rotor abilities, providing virtually all-weather transport, which is particularly important where we are in the upper Midwest, where we have a lot of bad weather. Advanced planning is necessary, and we have to be very proactive in ensuring that we have overlap between our ground, rotor, and fixed wing capabilities to minimize disruptions. There will be some disruptions, such as blizzards or wildly inclement weather in the South, whether it's a hurricane or tornadoes in the Midwest. There will be times that there is going to be a disruption. The effort has to be made at that point to minimize those disruptions by continuously reevaluating where we are with our ability to transport by one of those triad. Keys to success. Open and frequent communication, as I've said before, is paramount. The providers at all the institutions have to proactively address issues before they really become problems. Fostering an air of collegiality and collaboration is the key to establishing and enhancing the rapport and relationships at provider and administrative levels. We at hub facilities need to ensure that we are satisfying the educational needs by providing educational opportunities to enhance the hub's ability to return patient care into the community. It increases satisfaction with the community providers, hospitals, and patients alike. One of the keys, never promise more than you can deliver. In a hub and spoke, honest cooperation and collaboration can overcome any problem. Humility and avoidance of hubris. The goal is to provide the best care to the patient, and it must be a team approach from the community or private physician up through all the institutions to the hub. We need to value all members of the team, regardless whether they're a private practice physician, part of the spoke, or part of the hub. The target of our system is a target. It facilitates rapid transport of the patients and determines the best location of treatment, as you saw in the previous slide. Our effort is to have less than 20 minutes from hospital arrival to commencement of definitive therapy, whether it's in the cath lab or in the hybrid OR. We undertake aggressive surgical or cath lab intervention to salvage and stabilize the patient, which then allows us to determine the etiologies of the shock and initiate treatment working backwards. In the cases of ECMO and MCS, it allows us to stabilize the patient, correct their metabolic issues, address the underlying causes and comorbidities, and plan for bridge to recovery, bridge to a durable device, bridge to transplant, destination therapy, or palliative care as indicated. You can see with this program, we've been able to increase our volume across the board, both in ECMO as well as MCS over the past 3 years. Economies of scale as well as experience, as I said before, you can see the increases in volume have led to more experience, and with that experience comes better judgment, and both mortalities and morbidities have come down immensely. So in conclusion, embracement and implementation of the hub and spoke model, both within and without healthcare systems, is possible. The model is fiscally responsible, efficient, and results in excellence in patient care delivery by triaging patients to the appropriate facilities with the appropriate infrastructure and resources. It avoids expensive duplication of resources, improves outcomes, and returns patients to their community for follow-up, thus improving the patient experience as well as overall patient care. The key requirement is proactive, open communication between the hub and spoke facilities at both the provider and administrative levels. Please remember, the goal is excellence in patient care, so we check our egos at the door. With that, I thank you for your attention.